Well, welcome to everybody, and thank you for joining us today for our Health Matters webinar on osteoporosis. My name is Karen Inge, and I'll be facilitating today. And I'm sorry, I must apologise for our delay in starting, but we've had a few technical difficulties, but hopefully they'll all be resolved as we progress through this session. It's a very interesting topic. We have a record number of attendees today. So obviously you're either interested in prevention or you have osteoporosis and you want to know if there are great ways of managing it. Well, today you will definitely find out from two amazing women who are absolute stars and leaders in their fields. But before we begin, I would like to acknowledge the traditional custodians of the various lands on which we all find ourselves today, and pay my respects to their elders, past, present, and emerging. I extend that respect to any Aboriginal or Torres Strait Islander peoples participating in the webinar today. Well, today, as I mentioned, two superstars in the field, but we're first of all going to hear from Professor Natalie Sims, who's an internationally recognised bone biologist, and secondly, Dr Jasna Aleksova, an endocrinologist and bone researcher. After the presentations, we will have a short Q&A where you will have the opportunity to write questions to Natalie and Jasna. There is a Q&A button on the bar at the bottom of your screen, so please feel free to type your questions throughout the webinar. We will only be using the Q&A feature today rather than the chat or the raise your hand option. So I hope you all have your glass of milk ready, even if it's plant-based. Make sure it's fortified with calcium. We're going to learn a lot. So anyway, so I hope you enjoy it and get a lot of information from this session. So it gives me great pleasure to introduce our first speaker today, Professor, I was going to say my dear friend and colleague, but she's not a colleague, she's a wonderful friend though, and somebody I admire enormously, Professor Natalie Sims. Professor Natalie Sims is the Deputy Director of SBI. She's the head of the Institute's Bone Cell Biology and Disease Unit, an honorary professorial fellow at the University of Melbourne. Since starting her PhD at the University of Adelaide in 1990, she has worked to discover new treatments for common skeletal conditions such as osteoporosis and arthritis, as well as rarer disorders like osteogenesis imperfecta that affect the way the skeleton is formed. After her PhD, she worked at the Garvan Institute and then trained at Yale's University School of Medicine in the US before returning to Australia in 2001. Natalie started working at SBI as an NH&MRC fellow in 2006, and she's had various roles working her way up to the second top job at the Institute. Natalie was president of the Australian New Zealand Bone and Mineral Society. She is the associate editor of Endocrine Reviews and has held several editorial positions with numerous scientific journals. She has received several international awards in recognition of her leadership in bone research, including the very prestigious Paula Stern Achievement Award in 2020 from the American Society for Bone and Mineral Research. Her team currently investigates the way that cells within the skeleton communicate with each other to produce bone of optimal shape and strength. So over to you, Natalie.
Thanks a lot, Karen, and thanks everybody for joining us today. I'm just going to share my screen so you can see what I'm going to be talking about. All right, so what I'm going to give you is what I'm calling a bone biologist perspective on the skeleton and how it works. And so Karen's already told you that I'm a bone cell biologist and I head the bone cell biology unit here at SVI. And I've put on my first slide a picture of what some of the bone cells are that we study. And this is one of my favorite pictures. You can just see it through the keyhole here at the top. I'll just put my pointer on. Here, you can see on the top that there are cells inside our skeleton. And if you take nothing else away from today's seminar, remember that you have cells inside your skeleton and that they're constantly changing your skeleton so that it can withstand your daily activities. And that's really what I study, is how these cells work and how they maintain the skeleton. So I'm going to tell you a bit about them today. But first, I'm going to talk to you about why I'm so interested in the skeleton. And it's because osteoporosis is really a major public health problem. And many of you are joining us because you know that. But I'd like you to tell you some of the statistics about osteoporosis in Australia now, because it helps for us to tell others what osteoporosis is like and how it affects most people. In people over the age of 50 in Australia, we know that 1 in 2 women and 1 in 3 men will suffer an osteoporotic fracture. So this is how common osteoporosis is in our community. And with the ageing of the Australian population, this means that the total number of people who have osteoporosis is quite, well, it's very big. There's very many people, and the cost of repairing those fractures is extremely costly. To look at it a different way, one of the ways that we're really the first sign that anyone has that they have osteoporosis fracture. So some of you on the call now may have had a fracture. If you fall and you break a bone, that's often the first sign that anyone has that they have osteoporosis. And every 8 minutes, someone is admitted to an Australian hospital with an osteoporotic fracture. So this is another indication of just how common this condition is. And for many people, this first osteoporotic fracture is a sign that they need to take better care of their skeleton and that they're more likely to have a second fracture. But Jasna will talk more about the clinical perspective on that later in the talk. What I want to talk to you about today is a little bit about why older people are more susceptible to fractures and what are the different things that predispose us to getting fractures, and then how bone actually works is the main thing that I really want to talk to you about. So we know that throughout our lives, there are changes in bone structure. When we're very small, we have a very small skeleton. And so we know that the bone gradually gets bigger until when we're in our probably late 30s, early 40s, we have peak bone mass, probably the period of time from about 25 until about 50. Our bone strength is at its greatest. We have the strongest skeleton we're going to have because it has the most amount of material in it. And this is when we're most physically active as well in our life. So we've completed growth, the skeleton has finished growing, and we have enough bone there that our bone is very strong. But over time, gradually, the amount of bone inside our skeleton gradually declines as we get older. And this is important because when we reach a certain point, we're more likely to fracture because we have not quite enough bone to withstand the stresses of daily life, such as a fall from a standing height. So when we reach a point where our bone mass is just below this fracture threshold, you're much more likely to break a bone if you fall. And of course, for different people, you're going to reach this threshold at a different time, and hopefully you never reach it at all. But, you know, if you get older, you're much more likely to reach that than if you don't. So this bone loss is one of the things that makes older people more likely to fracture. The other thing that makes older people more likely to fracture is the loss of muscle that occurs with aging, and problems with balance or problems with sight that also occur. And Jasna is going to talk a little bit more about falls when she gets to her part of the session today. One of the things I'd like you to understand is that there are many, many different influences on bone mass. And this is something that the field has been working on for many years, and we've found so many things that change the skeleton. So obviously there's variability between individuals. So we know that genetics plays a role, but there's not one specific gene that's important for bone mass. There are many, many genes that play roles in determining someone's skeletal structure. And we can tell that by just looking around ourselves. We can see that adults have different heights and have different builds. And this is how our genetics has control over our skeletal structure. So genetics is really important, and that's something that happens at birth. We can't change our genetics. That's what we've got. But there are also things like epigenetics that change the skeleton as well. And this is a field of growing research where we're gradually learning more and more about how our environment influences the genes and how they're expressed in children when they're born, that then influence our later peak bone mass. Exercise is something that has an effect on the skeleton throughout life. It not only has an effect as we're achieving our peak bone mass, so if children are exercising a lot, they'll achieve a greater peak bone mass and have stronger strength as adults. And the same is true when we get older. Exercising more as we're older will help protect our skeleton, and it will slow the rate at which bone loss occurs. So this curve is less likely to reach the fracture threshold if we maintain good levels of exercise, and weight-bearing exercise in particular is helpful for that. Nutrition is also important. And again, this is important both when children are building their skeletons and as we're getting older, it's important to maintain good nutrition, particularly calcium, as Karen's already mentioned, but also enough protein so that the cells we've got in our body can make enough bone. One other thing, and this is a less positive effect on the skeleton, are chronic illnesses. And these have a major influence both on how we attain our peak bone mass, so chronic illness in childhood can have an effect, as well as chronic illness throughout our adult life and as we're aging. If we're chronically ill, we're more likely to have a greater reduction in the amount of bone that we have as we age. And one of the other things which Jasna will talk about is menopause that affects the skeleton. So women, when they undergo menopause, they do lose bone for a period more rapidly than what happens with aging in men. And this means that women are more likely to reach that fracture threshold earlier. And that's why women are more likely to suffer from osteoporosis than men. So what I want to talk to you a bit more about is what is bone actually made of? What is in our bones and how do cells make the bone that we have? So bone is a composite material. And what we mean by that is it means it's not just made up of one thing. It's got different components within the tissue. To me, I think the simplest way to understand bone is it's a specialized type of collagen, which has been wrapped in mineral crystals. So collagen, there's lots and lots of different types of collagen within our bodies. So we have collagen in our skin, and we also have collagen in our bone, but it's a different type of collagen that's in our bone. We've also got collagen in our cartilage, like in our ears, for example, as well. So collagen is a protein, and this is why eating enough protein is important in your diet. And this is a diagram of what collagen looks like. It's a triple helix. So it's a little bit like DNA in its structure, much larger because it's outside the cell. And collagen is really important in the skeleton because that provides flexibility to the skeleton. And then around the collagen, we have mineral crystals, and they wrap around the triple helix of the collagen. They become deposited, and this is what makes bone hard. So these two components for the skeleton are really important. Collagen is the protein, and then the mineral crystals are made up of calcium, phosphate, magnesium, all of these ions that we eat as well. This is a lovely illustration about why the collagen, how much collagen is in our skeletons. This is a really old piece of bone, actually an experiment done in the 1860s. And I was lucky enough to see this in a museum in Scotland. And what John Hunter did, who was a scientist and a surgeon in the 1860s, was he soaked a piece of bone to get all of the calcium out of it. And then he found that what you could do is it's completely flexible. You can tie knots in it. And we want our skeletons to be flexible so that when we jump and we run, we've got a little bit of bounce in our skeleton and it doesn't break just from normal daily activities. But the balance between the amount of collagen we have and the amount of mineral that we have in our skeleton is really important. And this is one of the things that we're studying at the moment, is how the balance between collagen, which makes bone flexible, and the mineral crystals, which make bone hard, can be maintained. Too much mineral, the bone becomes brittle. Too little mineral, and the bone is too soft and can't withstand our daily activities. The good news about our skeletons, and this is what gives me hope and makes me keep doing my research, is that the skeleton is constantly being renewed all the way throughout life. Tiny parts of our skeleton are being removed by one cell type and being replaced by another. And the calculations are that in adult life, all of the bone in our skeleton is replaced approximately every 10 years. This means, in theory, and this is the theory that I work on, is that if we have low bone mass or if we have bone that's poor quality, we can get our body to make a better quality bone as it gradually renews the skeleton throughout life. And these are the cells that make it happen. So at very tiny spots throughout your skeleton right now, little bits of your bone are being eaten away by these cells on the left, which are called osteoclasts. These cells spread out across the bone surface, and they make a little compartment where they release acids and they produce enzymes, which removes the collagen and removes the mineral, leaving behind a pit. It kind of looks like a snail trail, but it's actually a pit, not a bit of slimy stuff on top of your footpath. And then after these cells have departed, this bone is replaced by cells called osteoblasts. These are harder to see because they're connected into each other. They work as teams. And these are the protein-producing cells that make the new bone, which then fills up the pit that's been made by osteoclast. And it's all about balance between the activities of these two cell types. You have the same amount of bone resorption as formation, then bone structure is maintained. And this is what happens during that period of time when we have peak bone mass. As we get older, the activity of these cell types are not perfectly matched. The amount of resorption by osteoclast isn't matched by osteoblasts, which means that gradually over time, because of this slight imbalance at these tiny parts of your skeleton, eventually that adds up. And that's why the bone loss happens as we get older. So this means that when we're growing, and we're growing from a small skeleton to a large skeleton and acquiring peak bone mass, the balance is in favor of those bone forming cells. So there's more building happening of the skeleton. But as we get older, the balance shifts the other way, and the balance is in favor of resorption, and bone loss then happens. The other cells that are really interesting, and these are my favorite cells, and they were on the first slide I showed you, are these cells called osteocytes. And these cells sit right inside the hard matrix of the bone itself. So they live throughout the skeleton, and these cells are important because they can sense the strain that our skeleton goes under, and they can signal to the osteoblasts that form bone on the surface of bone. So this network is incredibly complex. I was involved in a study a few years ago with a mathematician where we were trying to work out how many of these cells are in the human body. There's 42 billion osteocytes that form 23 trillion connections. So these cells are actually, Jasna, can you just pop yourself on mute? We're getting some sound coming through from you. So the number of cells within your skeleton that are processing all this information is of the same order of magnitude of the cells that are in the brain. And these cells communicate with each other through these dendritic processes that you can see in the image here. Now, this sensing of strain is illustrated in this diagram here. It's a bit of an old picture, but I love it because it shows what happens when we go about our daily activities. Osteocytes within the skeleton, these processes sit within fluid-filled canals. And when there's a change in the stress of the skeleton, the cells sense that strain, and then they can send signals to the osteoblasts on the top of the bone to form more bone. And this is the reason why bone has the structure that it has. We can see here a diagram, and this is a very old picture showing that the form of the skeleton follows the function. If you use bone a lot, you have more bone. And this has been shown in studies of tennis players, for example, where the impact of the tennis ball on the racket causes an osteocyte response, which stimulates bone formation by osteoblasts. And in this example from an old paper in the 1970s, you can see that in the dominant arm of the tennis player, they have stimulated bone formation, and so they have wider and more dense bones. And this is just an illustration of how exercise affects the skeleton. And so at this point, I'm now going to hand over to Jasna, who's going to talk about different things we can do to prevent osteoporosis and ways that we can preserve bone loss. Obviously, what we want to do is to target the cells to try and stop and slow down bone loss, so that people don't reach that fracture threshold. So I'll stop sharing now and hand over to Jasna.
Thank you very much, Natalie. And I thought I'd just take a couple of minutes to introduce Dr. Jasna Aleksova. Dr. Jasna Aleksova is an endocrinologist and clinical researcher in metabolic bone disorders and osteoporosis. She completed her medical degree from the University of Melbourne, and then her endocrine training through St. Vincent's Hospital and Monash Health, with time also spent at Mount Sinai in New York. She has also completed a PhD, which examined the role of novel risk factors and imaging tools to improve fracture prediction in patients with chronic kidney disease and transplantation, and was funded through the National Health and Medical Research Council. She's a research fellow at Monash University and adjunct fellow at the Hudson Institute of Medical Hudson Institute, continuing her research in osteoporosis. Current studies include osteoporosis in those with chronic health conditions, hypogonadism, and exercise for healthy bones. Dr. Aleksova has been the recipient of numerous national and international awards and has been an invited speaker at national and internationally renowned osteoporosis conferences. She is involved in bone health education, convening multiple webinar series and education programs for medical trainees, as well as the education of medical students. She has been involved in the development of clinical practice guidelines and policy implementation. Jasna has also been on the editorial board and peer reviews for multiple international bone and endocrine journals. As a practicing endocrinologist, she has appointments at St. Vincent's Health and Monash Health and has her private practice at Cabrini Hospital, combining her clinical expertise with her research endeavours. So we're looking forward to hearing from Jasna, who's had enormous technical difficulties today with, not with her knowledge, but with the technology. But she's going to provide some advice on prevention as well as currently available treatments for osteoporosis. So over to you, Jasna. Hopefully everything works.
Thank you very much, Karen, and thanks for inviting me here today. So I'm just going to see if I can share my screen because there's been a problem.
Yes, we can see it, Jasna.
Oh, fantastic. So as Natalie has given us just a fantastic introduction to osteoporosis from a basic science point of view.
Jasna, just a moment. We're getting feedback from your, I think you've got sound on one of your, maybe on your phone. You'll need to turn sound off because we're getting feedback from you. Just try speaking again.
Can you hear me?
Yep, speak a bit more.
So I'm going to give you a clinical.
No, we're getting feedback still, Jasna.
What if I just turn this on? Is that better?
No, the problem's not the camera. It's with the sound that's coming through. Are you able to use earbuds? Have you got them available to you? That might help.
I think this is going to be better. You just can't see me.
That'll be fine. Yep.
My apologies. So I'm going to give you a clinical perspective and what we do as endocrinologists and what you can do to help prevent and potentially treat osteoporosis. So I won't harp on this too much because Natalie has already spoken about it, but I think it's really important to understand that osteoporosis is a definition that we use in a histological way, but also in a clinical way. And really, when we think about bone structure, osteoporosis is defined by low bone mass, but also a disruption in the microarchitecture of bone. And if you see here in a healthy bone, the networks of bone form an amazing network, and it's a beautiful lacework of interconnecting trabeculae. And here in the picture next to it, you can see that architecture is incredibly disrupted. So it's not just about bone mass, but also the architecture of bone that's really important, that may predispose someone to fractures. And really, it's such an important condition because when you fracture, you don't just break a bone. The sequelae to breaking a bone is really, especially as we get older, is the loss of independence. And that has huge economic burdens and also burdens on an individual and their family. And the risk of having another fracture within 12 months of that first fracture is up to 50%, depending on the age of that initial fracture. And really, there's a very increased risk of death that can happen after an incident fracture, and specifically after a hip fracture. So this is a really important condition to be aware of. And as Natalie mentioned before, osteoporosis, it's really a silent condition, generally until there's that fracture. And that's why screening is just so important. So we can actually try and prevent those fractures. And the way that we commonly screen for osteoporosis is using this machine that we call a dual energy X-ray absorptiometry, and we shorten that to DEXA. And you can see here in the images how that might work. We measure the bone density at the lumbar spine, which is the lower part of your spine, and at the hip. And you're positioned in these various positions to ascertain the best region of interest, which we're trying to measure. And the scan itself actually only takes, couple of minutes really, but the whole procedure takes about 10 or 20 minutes to have this done. And then the results look like this. So if we have a look closely at what you might get, this is the spine here, and it measures these lower 4 vertebrae of your spine. And what happens is you have a bone density score that's given to you, and that's a 2-dimensional score of a 3-dimensional object, don't forget. And that's actually in grams per centimetre squared. And then that number is converted into a T-score. And this is what most people commonly refer to. They're aware of their T-scores. And so what is this T-score? So the T-score is actually a standard deviation. It's how far away is your bone density from a normal person at age 30, because as Natalie mentioned earlier, remember, that's when we reach our peak bone mass. And so if we look at a bell curve, the T-scores are a standard deviation each away from that normal range. And the definition of osteoporosis is a T-score of minus 2.5. So that's 2.5 standard deviations away from that peak bone mass. And that's really putting people in the lowest 2.5% in terms of bone mass. So that's how we clinically define osteoporosis by T-score. But don't forget the definition also encompasses a minimal trauma fracture. And you don't need to have both factors to have that diagnosis of osteoporosis, which is really important, because some people will often think that, oh, I don't have a T-score minus 2.5, but they've had 3 fractures, so I don't have osteoporosis. Because don't forget, it's the architecture that may be disrupted, not just the bone mass. Now, the other thing that's really important when screening and using DEXA is to always ensure that your follow-up measurements are done on the same machine, because this is the only way we can compare changes in bone density. When you change machines, the bone densities aren't directly comparable. So why do we use bone density as a screening tool? Well, in these really large clinical studies, what we've found is that for each standard deviation lower bone density that you might have, there's a doubling in your fracture risk. So we know that although DEXA may be imperfect, it's a really good indicator for your osteoporosis and fracture risk. So as I've alluded to, bone strength, it encompasses both bone density and bone quality. And the DEXA can only measure bone density. And many people will fracture with a normal bone density or perhaps a low bone density, but not quite meeting that minus 2.5 criteria. And that's really, again, just highlighting the bone quality is affected. And we do have tools that can look at bone quality. And this is a tool called an HRPQ CT machine. They're very much a research tool and not clinically available. But you can see here in that this is a normal person's bone structure at the tibia and the radius. And then you compare it to someone with a very chronic condition, such as chronic kidney disease who requires hemodialysis. And you can see this outer rim, which is called the cortex of the bone. It's completely disrupted. And these patients have very high fracture rates because of this altered microarchitecture. So who might develop osteoporosis? So Natalie's already spoken about this lovely development of bone strength and bone mass as we go through childhood, and we reach peak bone mass in our adult lives. And then there's a gradual loss as we get older. However, in women, when menopause is reached, there's a large reduction in estrogen levels. Estrogen is normally a break in that bone resorption that Natalie was talking about. And when we take estrogen away, we take away that natural break in the digging phase of those osteoclasts. And that's why there's a sudden drop off in bone mass that occurs in women after the time of menopause. And this is really, I'll talk about a bit later, but this is where hormone replacement therapy can potentially play a role in trying to minimize that bone loss and potentially regain some of the bone loss that may have occurred around perimenopause. So women after menopause are at greater risk of osteoporosis and often reach that fracture threshold that Natalie was describing at an earlier age. That's not to say that men don't get osteoporosis, but it typically occurs a bit later because they don't have the same rapid reduction in bone mass that women do after menopause. So who else might develop osteoporosis? So there are many other chronic conditions that can lead to accelerated bone loss or early osteoporosis. Spinal cord injuries is a notable one, and that's partly because these patients become non-weight bearing. And when we're not loading our bones anymore due to these injuries, there's a rapid increase in that bone resorption again, and this can lead to reduction in bone mass. Again, airspace travel. Now, this isn't a very common problem, but it is in our astronauts. And these patients, when there's no gravity, there's no bone loading, these patients lose enormous amounts of bone very quickly. And I've mentioned here cerebral palsy. Now, this is just one neurological condition that can be associated with osteoporosis. Osteoporosis, bones have a huge amount of nerve fibers that innervate how the bone is metabolized. And when there's alterations in that bone innervation, this can also lead to disruptions in bone metabolism that can predispose patients to osteoporosis. Now, in these patients, there's also altered bone loading, and there's often different degrees of weight, and some patients actually can't walk. So there's a multifaceted amount of factors involved in why these patients may have osteoporosis. So as very generalized other risk factors for osteoporosis, advancing age, as Natalie, I think, very importantly highlighted, that post-menopause and early menopause is a really important risk factor for osteoporosis, and that's where the endocrinologist plays a huge role, and also the general practitioner in recognizing these patients and where hormone therapy may play a huge role. The chronic medical conditions, especially those inflammatory conditions that can lead to quite significant bone loss. And then medication use, prednisolone being only one example, but an important one. And then if we look at lifestyle factors, smoking, excessive alcohol use, calcium intake, vitamin D and protein intake, and then some of the micronutrients that we're learning more and more about and their importance, and then exercise. So I'll just go into these in a little bit more detail. And this is really about prevention and lifestyle factors, mainly in adult life I'll be talking about. So the daily dietary calcium intake. So really these recommendations change according to our life stage. Children needing between 500 and 1,000 milligrams per day, again, depending on their age. And then really in adulthood, we're aiming for about 1,000 milligrams. And in this picture, you can see where you're going to get the most amount of calcium in your diet. And they're really mainly from dairy sources, but also things like tofu and canned sardines that are going to be, you're going to be able to get 300 to 400 milligrams per serve. And then for women after menopause and men after the age of about 70, we're aiming for 1,300 milligrams daily. That's really hard for many people to achieve. And this is where talking to a clinical professional about potentially some calcium supplementation, if you're not able to reach those goals, may be useful. Now, vitamin D intake and exposure. And there's a diagram here that gives you an indication of how much vitamin D we might be able to ascertain from sun exposure. And this is quite variable according to the seasons and according to where you live. So here in Melbourne, in the summer months, 6 to 8 minutes of sun exposure is all you need for your general vitamin D intake. However, in the winter months, up to 50 minutes some people need. Now, I don't know about you, but I don't think that I spend 50 minutes every day out in the sun during between 10 and 2 o'clock. So you can imagine that many people need supplementation, especially as Victorians, to ascertain this adequate level of 50. But we generally aim over 75 for those who may be at risk of osteoporosis. So having our levels checked and supplemented as required is important. Now, exercise is really important, and that exercise really needs to be tailored across our lifespan. We need to maintain optimal loading and keeping active as children and minimizing screen time and getting outdoors and playing all those impact exercises. And then as we get older, we need to maintain bone, but also muscle strength, because muscle strength is really important for bone strength. Muscles pull on bones, and that pull creates a load. And that's what continues that strengthening and bone growing phase. And then as we get older, we need to reduce that bone loss and maintain the muscle strength. So that needs to be a combination of weight-bearing exercises, resistance, but also balance, because if we're going to if we can reduce the fall, we're going to reduce the risk of fractures as well. Now, when it comes to exercise as we get older, it's really important that this is a specialized program and that it's done under the supervision of physiotherapists or exercise physiologists. Now, I've just alluded to one important aspect, and this is really the spine. In people with spinal osteoporosis, we need to prevent certain exercises to prevent those compression fractures. So sit-ups. Sit-ups is our worst nightmare as osteoporosis physicians, because it really puts a lot of pressure on the spine, and we need to be avoiding that compression of the vertebra and bending at the hips, which prevents that load. And this is just one aspect of exercise and why it should be done under supervision, because not all weights programs and not all exercises are equal, and not all exercises are going to be appropriate in patients with osteoporosis. So just to summarize that exercise is important for growth and peak bone mass. It will maintain bone mass and also muscle strength, and it can help reduce some of the impact of osteoporosis and actually increase bone mass. Now, I'm just mentioning one program, which is called Onero, and this is based on Australian research from Belinda Beck, who works up in Queensland. And this is one of the few exercise prevention and treatment programs which is actually published and well recognised and has been endorsed by the Healthy Bones Australia network. And it's essentially an exercise program that uses those same principles that I've just outlined to help maintain bone strength. Now, the other aspect that we need to think about as clinicians is falls prevention. So ensuring that we have those balance exercises, ensuring that we reduce falls. Some of it's just simple tasks, and ensuring that we remove all those hazards at home, rugs and cords that are in the way. and ensuring that we have good footwear and that our eyes are checked regularly, that there's a nightlight if you're getting up and going to the bathroom, and that we think about medications that we may increase those falls risk, and specifically those blood pressure medications. And do you need them all? And is our blood pressure actually lower at nighttime than during the day? Do you need less blood pressure medications at nighttime, for example? And then we need to think about protecting the hips. And that really, again, comes to improving our leg strength. And there is some evidence to suggest that hip protectors may protect against hip fractures, but that's a little bit, it hasn't been well thought out in some of the evidence trials. And then treatment. So who is going to need treatment above and beyond these lifestyle measures? So this is a very simplistic way, and always when we think about treatment, it does need to be in the context spoken with your healthcare professional. But if you've had a minimal trauma fracture, so that's a fall from standing height, and you've had one of these classic osteoporotic fractures as a result of that fall, so that's a hip, a spine, or a wrist fracture, or a rib, shoulder, or pelvic fracture, or if you've had some imaging and you'd shown a spine fracture on imaging. Now, 50% of spine fractures are not actually felt, so they're asymptomatic. So that we sometimes routinely do some imaging to see if there's been a compression fracture. And if you've had either of those, if you're over the age of 70 and you have a T-score of -2.5 or lower, of course, we're going to optimize those lifestyle measures we've already spoken about and correct any other reversible measures. But that's when we're going to have a strong consideration for other anti-fracture therapies. So what might we consider? So if we think about the medications that strengthen bone that's already present and reduce the bone loss that's occurring, known as, these are anti-resorptive medications, we think about hormone replacement therapy, especially in women who are in the early phase of that after menopause. Other hormone therapies such as raloxifene, which is a slightly different, it's not a hormone replacement therapy, but it does have estrogenic properties. And then there's the bisphosphonates. And these can come in oral tablets or intravenous formulations. And then another medication known as denosumab, or the brand name being Prolia. And then in certain population groups, we would think about anabolic therapies. Now, these are medications that build new bone and then would require mineralization after that. And there are two anabolic therapies that are currently available in Australia, and that's called teriparatide, and their brand names are Forteo or Tarossa, and romosozumab, which is a newer anabolic therapy that's been available now in Australia for a couple of years, and that's marketed as Evenity. And the choice of medication would be dependent on your age, your fracture status, and also whether you've been treated previously. And these are all discussions that you would have with, your GP or your endocrinologist. And then if we have a moment, this is just an area of research that that I've been involved with through, my PhD and now beyond. And I look at bone health in the chronic kidney disease patients and those with transplantation. Now, these patients have really quite significant mineral abnormalities that impair their bone quality. And these patients are at a very, very high fracture risk. And unfortunately, the DEXA screening is really unhelpful as a fracture risk prediction to try and ascertain which of these patients will go on to fracture and who should be treated. And so this diagram that I alluded to earlier was from a patient who is receiving hemodialysis. And in the middle one, you can see that this is a patient who's not quite on hemodialysis, and their cortex is being disrupted. And as their kidney disease progresses, it just gets further and further, further disruption in that architecture. And that's using a very specialized tool called the high resolution peripheral quantitative CT. But that machine, there's about 3 available in all of Victoria, and it's about $1 million machine. So it's not particularly available. So my research has been looking into imaging tools that are widely available and that are not cost prohibitive. And so one of the tools that I've been looking at is this trabecular bone score. Now, this is actually based on the DEXA imaging, and it's available at some centres already, and it can help predict fractures even in the general population. Now, what it does, it uses those lumbar spine images from the DEXA, and it takes a surrogate measure of the architecture of those images, not just the bone mass. And then it produces a score of basically a surrogate of architecture, not just bone mass. And that score can help us define the fracture risk similar to a T-score. So it actually produces a T-score, but for the trabecular bone. And I've been using this in my kidney disease patients, and this is actually proving to be a helpful measure, more so than the DEXA in predicting fracture risk. And the other tool that we're looking at is looking at different parameters of the hip and looking to see whether different sites of the hip and the different types of bones present at the hip using the DEXA can help ascertain fracture prediction in these patients. And that's partly because these patients have a really altered microarchitecture. And so those changes can actually be seen on a DEXA, which normally can't be seen on a DEXA in the general population. So the advantage to this is that it's widely available, it's used on the DEXA machines, and it's very cheap. And that's part of the research that I'm undergoing at the moment. And I think the lovely thing that we have with at St Vincent's is that in our clinical bone meetings, we have a bone meeting at the end of every session, and Natalie and her group, they come to our bone meeting, and we think about, okay, here's a problem we've got in our patients. How can we try and solve it? And Natalie and her team, they go away and they think about in the mice model, how can we actually then improve things? And this is the lovely thing we have at the moment at St Vincent's Hospital and St Vincent's Institute, that we can think truly from the bedside model, okay, what are the clinical problems we're having with our patients? Why we don't have a solution at the moment, and then we can go away and think about that through models in animals or in cells and in the lab to help try and improve our patient care. And so this has been a fabulous network that we have here at St Vincent's. So I think that's the end of my slides, and Natalie has some more things to say about what her research is doing at St Vincent's at the moment.
Great. Thanks so much, Jasna. It's very interesting. Please, just a reminder to put any questions you have in the Q&A section. I'm sure that you have a lot of questions, but in view of time, I'll hand straight over to Natalie. We'll come back to questions at the end, because I'm sure, Natalie, you'd like to tell us a little bit about the research that you're doing at SVI.
You're on mute.
Natalie, you're on mute.
Yes, sorry, I said all these clever things and you missed them. I wanted to say thank you to Jasna for everything that she was saying. And I'll tell you a little bit about the research that we're doing at SVI very briefly. As Jasna has mentioned, one of the critical problems we have is that bone strength is not only determined by something that can be measured by DEXA, it's also determined by how wide a bone is, how porous it is, and what the quality of the material is. And these are the things that we're all trying to understand here at SVI, and working out how the cells within the skeleton control each of these factors. We're particularly interested in finding better ways to prevent fractures of cortical bone. So that's that outside structure that Jasna was showing you. And this is so important for hip fractures and wrist fractures, which are the most detrimental fractures that people suffer with osteoporosis. And unfortunately, the treatments that we've got, they're pretty good, but we could do a lot better at preventing cortical fractures because they're not so well targeted by the current treatments. So what we're working on are basically thinking about the cortex like a pole. How can we make the cortex thicker? How can we make it wider? And how can we improve the material that the bone is made out of to make our hips and wrists strong enough? One of our researchers, Dr. Natalie Sims, is working on a mouse model that we have here, which overexpresses a protein called PI3K, and it causes incredibly thick cortical bone. She's working to understand how the cells within bone express that protein and use that to make the bone thicker. By discovering this method, this could lead to a way that can specifically add bone to the cortex to make it thicker where we need it. Another project that we're doing, looking at the material of the bone, is to see how osteocytes, these cells that I've introduced you to that are inside the skeleton, control the material around them and can make the bone material stronger. And we got through this, and this is work being done by Martha Blank, who did her PhD in my lab, where we were looking at bones which we found in mice that didn't express, and this is a different protein called FRNB2. They had very fragile bones, but had normal mass. So it's all because of the material quality of their bone. In looking at the very molecular structure of the bone, we found that the problem with these mice is that they have too much collagen and too much mineral as well. So Martha's working to understand how this works, and by understanding that, we could find treatments that can actually make the bone material itself better. We're also using the Australian synchrotron to study aging human bone, and this is looking to see what happens when bone gets older. And this is work being done by a new PhD student in our lab, Mary Louise Fack. And she's working to find out how the material quality of bone changes in older women and older men compared to young women and young men by using the synchrotron to look at these components of the material. And then finally, we've been looking at cortical porosity. We know that as we get older, our bone becomes more porous, and that's one of the things that makes it more fragile, but there's no treatments that can target that. Again, we have a mouse model here, and this is being studied by another Natalie in our lab, Natalie Coe, a new PhD student. She's looking at a mouse model that has increased pores and defective osteocytes. You can see that they don't have the same beautiful arrangement that osteocytes normally have within the skeleton. So she's trying to understand how all of that works. Through all of these different approaches, my big hope is that what we'll be able to do in the future is to have better ways of predicting who's going to fracture by developing new diagnostic tools, and we'll be able to stop the formation of holes and be able to fill those holes and improve material quality, even in people who've already got past the fracture threshold. So I'd like to finish there because I want to make sure we've got a bit of time for questions. Thank you.
Thank you, Natalie. There are so many questions already, so I hope that people can stay a little bit longer online to hear some of your answers. So there are a couple of clinical ones and a couple of sort of policy ones. I might start with the policy one. Why hasn't osteoporosis become part of a national education campaign similar to skin cancer, bowel cancer? How can we encourage the government to address these issues at a national level so that we can really prevent the disease? Who'd like to have a go at that?
I'll have a go at that. Because I've been the president of the Australian and New Zealand Bone and Mineral Society, this is something we spend a lot of time working on. And so there's both the philosophical and the practical answer to this. I think from a philosophical perspective, one of the reasons why osteoporosis hasn't been part of a strong national campaign is unfortunately because it's a condition that affects the elderly. And I think we're far more motivated as a community to be concerned and be supportive of issues that affect people who are of working age, or particularly children. Having said that, there have been national education campaigns. They're just very small. So there are organisations like Healthy Bones Australia, which is doing advocacy work to try and promote osteoporosis awareness within the community, but the funding that they have is very limited. So this is one of the reasons. So the practical reason is money, but then there's also the emotional reason. How can we encourage the government to address the issues? It's all about people power. Write to your politicians, talk to them about this. We knew that when romosozumab, the new treatment that Jasna was talking about, to get that approved and to get that on the PBS, we needed patients to write to the government to talk about their experience of osteoporosis, because it's not very well known among the community what it's like to have osteoporosis. It's something which is not spoken about because older people maybe don't complain enough. But yeah, write to your politicians and tell them how important this is.
Thanks, Natalie. Clinical questions for you, Jasna. Hi there, I've been taking Prolia for the past 6 years. Is it safe to stay on this medication long term? And is there a newer alternative?
Yeah, really good question. So Prolia is there's feedback here. Sorry, can you hear me okay?
Yes.
So Prolia is a fantastic drug for treating osteoporosis, and we have now data out to 10 years showing that Prolia is effective and safe to use out to 10 years. And that data is probably about to be extended out to 12 years shortly as well. The issues around ongoing treatment are partly to do with ongoing efficacy. So is it continuing to increase your bone density and reduce your fracture risk? And that's something that we're sort of yet to establish, because the further out we get in those studies, the fewer patients we have to be able to assess whether there's a true reduction in fracture risk if you continue to use it. And the other aspect is that although we are increasing bone mass, are we actually reducing fractures? Because what happens with long-term use is that we're changing the material property of bone, which can increase bone mass, but sometimes it gets so dense, it can actually become brittle. And so we sometimes worry that if we're going to keep using it forever, over 10, 15, 20 years, that we actually make bones so dense that it actually becomes brittle and increases your chance of these very unusual fractures called atypical femoral fractures, which you may have heard about in the community. Now, these are incredibly rare. So this is something that's really important to be aware of. Very, very rare. But we do think that having some treatment intermission between your osteoporosis medication may be important. Now, Prolia is not a drug that necessarily can be stopped, and it's something that needs to be continued 6 monthly without a break, because that's the mechanism of its action. Now, in terms of should you continue it ongoing, that sort of becomes a question of, has your osteoporosis been managed? Have you stopped having fractures? Has your bone density improved? And if there is a consideration of saying, yes, maybe a break may be considered, you can't just stop Prolia. You really need to speak with your clinician about how to potentially stop Prolia, because there's a whole problem with that. And when you consider the question about are there alternatives, well, the alternatives really are other anti-resorptives, such as a bisphosphonate, or the anabolic treatments that we were mentioning. But Prolia is just...
Sorry, no, go on.
I was just going to say Prolia is just really important that you can't stop it without having a discussion around how to stop it. That's a really important thing at the moment to be aware of.
Okay, thanks, Jasna. Natalie, would you like to comment on that, or anything to add?
No, I think Jasna's covered it quite well.
Okay.
Yep.
Okay, so how often should someone over 60 have a DEXA scan?
So I might answer this question as well. So typically, we wouldn't do bone densities more frequently than every second year. And that's partly because it takes time for any effects to be seen on these DEXA scans. Now, in some instances, we may do them every 12 months if there is a concern that there's rapid bone loss going on. So if someone's had a transplant, for example, that may be a time when we might do it more frequently, or if they've got severe inflammatory conditions, or they're having large doses of steroids, for example. And at the same token, we may actually do it less frequently if someone doesn't have osteoporosis on their initial DEXA screening, there's no other risk factors, we may actually extend out that next bone density by even out to 5 years. So typically we say every 2 years, but there are times where we may reduce it or may actually extend out that next bone density.
Thank you. How much exercise can improve bone density and bone architecture? How much do you need to do? And I know not swimming, you don't swim. I mean, you could swim, but not for bone health. How often? How much? And can
I jump in on this one, Jasna?
Sure.
Yeah. It depends, I think, is the simplest answer. So it depends on how old you are. It depends on the type of exercise that you're doing. Whether the thing that you most importantly is whether it can increase your bone strength. We know from studies using the Anero program, which Jasna mentioned, which are heavy weightlifting exercises done under careful supervision of an exercise physiologist, that they can prevent fractures, which is amazing, because for years it's been very difficult for the field to find any effective exercise on bone density, but this program did. And the thing about this is that they're very heavy weights. And so you're basically lifting the maximum weight that you can, which is why it's important that it's done with an exercise physiologist. With children, the amount of exercise needed to improve bone mass is much less, because children's skeletons are still growing. So exercise for children, they don't have to be going out doing weights. So don't think your kids have to go and do weights. They just running around, being active in children, jumping, playing, that's really important, stimulating those osteocytes within the skeleton. But for those of us who are older, the most beneficial exercise are things that involve really doing weightlifting, weight-bearing exercise. Having said that, exercise has benefits for so many things. So don't decide that the exercise you're doing is not good enough. Any exercise is good exercise. It just might not strengthen your skeleton, but it can preserve what you've got there as well.
Okay.
I think I'll just jump in and make a comment that I think what the Anero program showed is they did it 3 times a week for about 30 minutes. So I think that's something that a lot of patients will want to know exactly what they should be doing. So it's those heavy weights that needs to be, the other thing is progression. So when you start off with your 5 kilos, your 10 kilos, that you're then actually progressing those weights, because your bones get used to a certain degree of load, and we need to continue stimulating them by increasing that load. And that's again where that exercise physiologist and the supervision comes into it, so that heavy weight lifting is safe but progressive.
Now we're running over time, but I'm going to take the liberty of asking you a couple more questions, and then I'll have to stop it. But they're very interesting questions, so people will bear with us. I'd like to ask our experts what they think. So let's have a look at breast cancer treatments. If you're unable, you've had breast cancer treatment, you're unable to have HRT, you're on endocrine medication, how can you try and prevent osteoporosis besides regular exercise? Anybody got any ideas? Jasna?
So breast cancer is a very common problem, and it's a great question to have asked. So in these women, sometimes these women are very young, in their 30s. So the breast cancer treatment has usually caused early menopause in some of them, but even if it's later in life. But that's one aspect, that early menopause occurs, which predisposes that early accelerated bone loss and reaching that fracture threshold earlier. And then the endocrine therapies that we're commonly using in breast cancer basically eliminates any estrogen that's left in our bodies. And that's another insult. In these women, there are studies to show that the anti-resorptives are beneficial in preserving bone health. So depending on your baseline bone density and if there's been any fractures, we do often use anti-resorptive medications in addition to ensuring good calcium intake, ensuring vitamin D is replete, ensuring there's lots of weight loading on bones through exercise. But if they meet certain criteria, then we would intervene with anti-resorptive treatment to try and preserve their bone health whilst they're on endocrine therapy. When the endocrine therapy ceases, we often stop the anti-resorptives and see what happens, because it's those medications that often have a huge role to play as well.
Well, it sounds like they need to go to see an endocrinologist. So they're the bisphosphonates, are they, like Fosamax, etc.?
Usually the bisphosphonates, some of the oncologists will use denosumab, but again, I won't go into the specifics, but because of this, you know, the inability to stop Prolia suddenly, we often use the bisphosphonates in the first line because it gives us more dosing flexibility.
Okay, one more question, and then we'll have to close. But it's about the recent, with the more recent and safer body identical HRT. Can this be more of an ideal long-term treatment to protect bone mineral density and bone structure, especially when complementing this with targeted strength training? Yes. Do
you want me to answer this one? So the standard hormone replacement therapy, whereby we use estrogen and progesterone, can reduce the bone loss at the time of menopause. And we often use this usually to around the age of 60, because we have studies that have shown that up to this age, it is safe and effective in terms of bone loss. But after the age of 60, we have to then start considering the risks. Now, the risks start to increase after this age of 60 because mainly the cardiovascular and clotting risk. As we get older, our cardiac risks elevate and our clotting risk naturally escalates. And then there's also the breast cancer risk. So more and more evidence is coming to light as to the risks that are associated with HRT. And to date, around that age 60 point is where we start to think that the risks of clotting and the risk of cardiovascular disease starts to become greater than the benefits of HRT in terms of those bone effects. And we are using natural estradiol and natural progesterone more and more commonly. And the older studies where we use that sort of arbitrary 60-year cutoff tended to use the synthetic estrogens and the synthetic progesterone. So we do believe that the natural estrogens and the natural progesterones are safer because of their absorption through the skin, and they don't get metabolized through the liver, which is a safer approach. But we just don't have the evidence. And to be honest, I don't know whether there's going to be a big trial using these new medications, because many women aren't going to want to enter that trial in case of the effects. Because what happened in the old Women's Health Initiative, which is where this big, a lot of this literature around hormone therapy came out, then showed a big increase in breast cancer, which was subsequently reanalyzed and things. So I don't know whether we're going to get the evidence for these bioidentical and the natural estrogens, but we know that they're safer, and they're safer from a cardiac point of view, from a liver, from a lipid perspective, and they have good effects on bone. So I think as clinicians, we are using it a little bit more than the typical 60-year cutoff, but I don't know if it's going to be a use it till the end of your life type approach. And I just don't know whether we'll have that evidence.
Well, I might have to leave it there, but there's just other questions on the different types of strength training programs besides Anero, like the OsteoStrong program, Keyser. Just a 2-second comment from Natalie and Jasna? All those programs are good?
Natalie, did you have any? Do you want me to?
You can take it, Jasna, because you've probably got more experience with them than.
Yeah, so I'll just mention KESA because KESA is becoming increasingly popular. KESA is a strength program. Okay, so they have their own set of machinery and they perform strength training at the KESA gyms. There isn't published evidence to say that, yes, they increase bone density, but they work on the same principles that we've been discussing. They work on strength training, resistance, and impact and load. And it's the same with many other exercise physiology groups and other physiotherapists with an interest in osteoporosis. If they have the knowledge and understand how osteoporosis works and how they can treat it, these impact classes are going to be beneficial. So although, I'll give 1 to 2 seconds, and then I'll mention OsteoStrong. OsteoStrong is quite different. They work on a different principle. It's a 30-minute or 60-minute loading once a week at maximal intensity. There isn't really good, strong evidence for it, and the evidence that's published is in numbers of about 15 patients. There's a study going on at the moment in Greece and actually through Monash University, which we're involved in as well. So maybe more evidence will come to light as yet, but quite a different program.
Well, thank you. Look, we could go on and on because both of you have so much knowledge. So it's so interesting to listen to what you have to say. So I'm sure on behalf of all the participants, I'd like to thank Professor Natalie Sims and Dr. Jasna Aleksova for your incredible presentations. I do apologise to everybody for going a little bit over time, but I really didn't want to stop the discussion. So thank you for those who have actually stayed on. Thank you also for attending. For those that would like to watch this webinar again or have friends or family that may be interested in watching it, we will be sending around the recording in the coming days. We'll also be sending out a survey for your feedback so we can continue to bring you engaging virtual events. We would appreciate if you did take a few moments to complete it. Now, this was a free event. You certainly received a lot of information, but if you would like to make a donation, we wouldn't say no. So if you would like to make a donation to support our research into osteoporosis disease and help Natalie with her program, please head to our website, www.sbi.edu.au, or contact one of the team at the SBI Foundation. And if you would like to join our mailing list to receive event and research news or are interested in hearing more about the work that SBI does, please email the SBI Foundation at foundation@sbi.edu.au. I can't thank you enough. My name is Karen Inge and I'm signing out. So have a wonderful afternoon and thank you for attending. Goodbye.